move on to our next presenter, Laurie Smith, who is going to share with us the implementation of HPV-based screening and self-collection, and in particular, our experience here in British Columbia. Laurie Smith is the program manager for the Global Control of HPV research program at the Women's Health Research Institute, and she has been working in cervical cancer prevention research, including HPV-based screening, for over 15 years. She is also a certified practice nurse and has conducted cervical screening to patients for several years. So welcome, Laurie.
Thanks so much, Shirley. And thank you all for taking time out of your evening to spend with us tonight. I'm really grateful for this opportunity. And I want to talk to you tonight about HPV primary screening from research to policy. So I'm going to take you on a little journey. Slides aren't, there we go. How did we move from this to this? So we're going to start with a little lesson in history. Cervical cancer was once one of the most common causes of death for Canadian women. George Papanicolaou, Dr. Pap, as he was commonly known, was a pioneer in the early detection of cervical cancer. He first discovered the value of cytology, or looking at cells under a microscope, in diagnosing cervical cancer way back in 1928. But it wasn't until 1941 that his work was well received by his peers in the scientific community. It was after that that the Pap smear became the gold standard for screening of cervical cancer. Here in British Columbia, we had the establishment of the screening program way back in the mid-50s. It was the world's first organized screening program, and BC remains a leader today in cervical cancer screening. In 2021, the screening program celebrated 65 years of screening in BC, and over that period of time, it saved thousands of lives in our province. So for decades, screening with the Pap smear has been considered a public health success. It's decreased cervical cancer deaths up to 70% or more, but it does have some limitations. It has a higher false negative rate, so we need to do it more frequently to decrease the chances of a false negative. It also has access barriers, which can reduce uptake, can make people not go for their Paps. For example, people that live in rural and remote locations may have difficulty accessing, or people have to take time off work, or if people have a history of trauma or for various cultural reasons are not comfortable with a speculum exam. And its ability to decrease cervical cancer rates has plateaued. Then in the 70s, Harold Zurhausen started to look at human papillomavirus as a cause of cervical cancer. In the 80s, his team identified two types of HPV that are associated with most cervical cancers. But it wasn't again until the 90s that his theory became more accepted, that HPV was the necessary cause of cervical cancer. This then opened the door to the world to develop ways to prevent cervical cancer through developing vaccines and new approaches to screen. So what we're saying here is that research surrounding HPV vaccines and HPV testing really has been ongoing for decades now. So what does human papillomavirus have to do with cervical cancer? There are actually over 150 types of HPV, of which about 40 of them can infect the anogenital region. HPV is a very common virus. It's sexually transmitted through intimate skin-to-skin contact, so not through bodily fluids like something like HIV. It is skin-to-skin contact. Most sexually active people will be exposed to HPV at some point in their lives, but most infections are asymptomatic. A person doesn't even ever know they have an HPV infection, and they resolve within about 2 years through the body's own immune system. There are different types of HPV, and we classify them as low risk or high risk. The low risk types are the ones that are associated with genital warts, and they don't cause cancer. The high risk types are the ones that we see being related to various cancers. These oncogenic or cancer-causing types can cause changes to the cells that then lead to cervical, vulvar, vaginal, anal, and those head and neck cancers. HPV types 16 and 18 are two high-risk types, and they are responsible for about 70% of cervical cancers around the world. It takes many years for cervical cancer to develop. So it's a long-term infection with one of those cancer-causing types of HPV that is necessary for cervical cancer to develop. If a high-risk infection doesn't go away on its own, or if it's not detected or treated, it may lead to cervical precancer or even invasive cancer. But again, it takes many years for this to develop, usually 10 or more after an HPV infection. And a lot of people might think cervical cancer develops quickly because they've had to have PAPs frequently, but it's because of that false negative rate. And an estimated 1,550 Canadians were diagnosed with cervical cancer in 2023, and we estimate about 400 people will die from it. And that's 400 women who are mothers, sisters, aunts, friends, 400 people that mean something to everyone in their lives. So why HPV testing? Well, HPV detects the presence of HPV DNA, and which is the cause of cervical cancer. It has a higher sensitivity than the PAP, so it has a lower false negative rate. And what this means is that we have a greater confidence that a true HPV negative result doesn't have any association with disease. And as I mentioned, PAPs are done every 3 years to increase their performance. So with this lower false negative rate with HPV testing, we can extend that interval between screens beyond 3 years. The pap smear, which we also call cytology, takes a sample of cells from the cervix and looks for abnormal cells that have already occurred because of an HPV infection. With HPV testing, since we're looking for that cause of the abnormal cells, we can actually identify those at risk for having precancer before those changes to the cervix occur or before they are progressive. So now I'm going to tell you a little bit about the HPV screening research that we've done here in British Columbia. In 2006, a team of researchers at BC Cancer, UBC, and the BC Centre for Disease Control received a pocket of federal funding money to explore HPV testing for cervical screening. And this funding made possible a study called the HPV Focal Trial, and it was the largest North American trial of its kind exploring primary HPV screening. And the main goal of the focal study was to explore the effectiveness of HPV testing every 4 years compared to the PAP every 2 years. People were recruited in Greater Vancouver and Victoria from 2008 to 2012, and they were followed up to 4 years through to 2016. Over 25,000 women aged 25 to 69 participated. When they went to their provider, to their doctor or nurse practitioner, the cervical sample was obtained. And when it was received at the laboratory, it was randomly assigned to receive either HPV testing or the PAP. Sorry there. And the results of the focal study showed that at 4 years, people that had HPV testing at study entry, and then again when they exited the study at 4 years, had a much lower likelihood of having precancer compared to those that had the cytology or PAP testing at when they entered the study at 2 years, and then when they exited at 4 years. So what this really means too is that we found cervical precancer earlier and better in those who had the HPV testing. We also know now that one HPV test is protective for precancer up to even beyond that 4-year mark, up to 7 years of follow-up. We also invited study participants to participate in acceptability surveys, and they reported that HPV testing was acceptable to them. So what the focal study did was add to the global body of evidence showing the importance of HPV testing for cervical screening. And these studies actually have helped inform the government and BC Cancer for the eventual transition to HPV testing here in British Columbia. They're also included in the Canadian Partnership Against Cancer Action Plan for the elimination of cervical cancer from 2020 to 2030. And the focal study it remains informative and relevant, and we can continue to look at questions around HPV testing with focal study results. So let's talk a little bit now about self-screening. This is very exciting for people. It's probably people have seen a lot about this in the news lately. So with HPV testing, the HPV infection can actually be detected in cervical cells or in vaginal secretions. So this actually creates new opportunities to decrease barriers to screening and to really make it more accessible. People can collect their own samples vaginally, easily and painlessly. So a person, when they're doing their own sample, they don't need to try to find their cervix or take a cervical cell sample like they would if a doctor was doing it in their clinic. It's a simple vaginal swab. This really empowers people in their own screening journey. Self-collection has been proven to be as accurate as a provider-collected HPV test, and it's also, as one can imagine, highly acceptable. We started self-screening research in BC almost 20 years ago. Dr. Ogilvie received a small pocket of funding from the Women's Hospital to launch a self-screening study to street-involved women in the downtown east side. So again, we have almost 20 years of experience leading this kind of work, not only here in British Columbia, but also in sub-Saharan Africa. And all of our research is community-led and partnered with various communities leading the charge with that research. We've worked with Indigenous communities, immigrant communities in rural and remote locations, and also in urban settings. And in 2018, through the BC Women's Health Foundation, Dr. Ogilvie and team received $10 million in federal funding towards acceleration of elimination of cervical cancer in Canada. And we call this study, or the suite of projects, ACE projects. With this funding, BC really is leading the charge in HPV vaccine and screening research, which can contribute to the elimination of cervical cancer goals. And this funding contributed to a large BC self-screening pilot, which helped inform and help plan for primary screening here in BC. And I'll tell you a little bit about that pilot too. This pilot was conducted from December 2021 to 2023, so just about 2 years. And the screening program collaborated with a bunch of different communities across BC. When women and individuals with a cervix aged 25 to 69 were invited to participate in self-collection. And those that were invited were people that had no history of a screen. They were underscreened, so their last screen was 5 or up to more than 10 years before, or they were right on time for screening. We also explored different invitation methods. So people either had the kit directly sent to them or they were invited to request a kit. And again, acceptability surveys were sent to participants as well. And as of last summer, over 61,000 people have been invited, 29,000 kits sent, and almost 13,000 kits returned. And I think maybe this 42% return rate may appear small, but keep in mind, a lot of these people were never screened or very underscreened, and this gave them an opportunity to have a screening that they might not have otherwise had if they didn't get the option to self-collect. We found that mailing kits directly had a much higher uptake rate than inviting people to request their kit. And the surveys, like other research about acceptability, found this to be highly acceptable and that they would again do it in the future. So almost 20 years of research here in BC around HPV screening has paved the way for the implementation of primary screening in our province. And in January 2024, as you may have seen in the news, the province began the official transition to HPV primary screening. So what this means now is anybody that's due for screening and eligible for screening has options for how they can have their sample collected. They can order a kit and have it do the vaginal swab, or they can go to a provider, as they may have in the past, to have their sample taken. Here are some examples of some of the materials that the screening program has developed. And the purple package there is the one that a person would receive in the mail if they ordered their kit from the screening program. And sorry, I don't have a QR code, but there is the link there if anyone's interested. So in summary, research and innovation have been at the cornerstone of advances in cervical cancer prevention, all the way back from the PAP to HPV now. Research, discovery, and innovation are at the root of all evidence-based medicine. And because of these advancements, we have the opportunity to eliminate cervical cancer. This is achievable now more than it ever has been. And no one has to die from this preventable disease. And we hope that we move closer and closer to those elimination goals. And I'll just leave you with this two last images. So these were all the latest and greatest of their time. And probably if you really wanted to use one of them, they would still work. They would still be okay. But through research and innovation, most technology changes and improves over time. HPV screening is such enhanced technology. Thank you.
Well done. Thank you so much to you and your team. Wow. Laurie, I just did a quick calculation while you were presenting. I've been getting the pap smear for 41 years, and I just learned so much
Oh,
from the
good.
presentation tonight. That's on
That's
me,
good.
probably because I didn't ask enough questions in my younger days, but thank you for that. I'm curious, has there been pushback from certain participants, certain groups? For example, that it says cervix screening on the test, but you actually don't need to find your cervix in order to do the swab.
Right.
That we could take away and share with our friends?
Yeah, and that's a great question, Shirley. And I think, the messaging can maybe be confusing to some people, but there is a lot of resources on the screening program website that can help clarify that for people. Um, it's called cervix screening because we are still trying to prevent cervical precancer. But that message may be getting lost with some folks, but hopefully it's presentations like this or people deep diving into the cervical screening website to read some of those materials, and us telling our friends that it is just a vaginal swab that is needed. I also think these are early days of a significant transition in public health, and over time this will become very familiar to people, and we just want to also, like I said in that slide, it's really about this full transition to HPV testing, but the choice of how people can have their sample taken. Those that would prefer to still go to a provider to have their cervical screening obtained can still do that, and those that would prefer to do it at home have that option to do that as well.
That's great clarification. I have a couple other questions for you. Is there research being conducted on the uptake of the kits by newcomer women since its launch? I'm assuming
Um,
Canada, I'm assuming.
Yeah, and I probably can't speak on behalf of the screening program. They are doing as much a collection of information as possible. Whether or not they're able to tell if people are newcomers to Canada from how they order the kit, I'm not sure, but I think that's a great question that would be very interesting to find out.
Amazing. And also just some clarification. Is there a reason why the eligibility age starts at 25?
Yes, that's also a good question. HPV is very, very common in people, typically more common in people under the age of 30, and also transient infections. As I mentioned, they typically go away in about 2 years or time. So we don't want to screen people too young and find infections that would otherwise go away on their own. In addition, cervical precancer and cancer are very, very low in people under the age of 25. And many years of research have explored that. And it was, I believe, in 2016 that the screening program raised that age from 21 to 25 for screening.
Thank you. And Dr. Hittman has a question for you.
Yeah, thanks so much. It was really interesting. And I had a couple of things actually. One was, I'm curious, do you know if the Canadian Task Force on Preventive Healthcare is currently updating their guideline? Because it's from 2013 and it says like, you know, will be revised once
Yes.
more data is available, and there's now a lot more data available for HP.
Yeah. I do believe that's in the works. Now, when that will be coming out, I'm not sure. And I think there are also um, provinces are in very different stages of implementation of HPV-based screening. So I, I feel that that will be coming soon, but I don't have a date. I agree with you that it's, it's older now. Even when the guidelines changed with cytology and intervals and the screening start age, but it's probably coming sooner than later.
Great. Well, it's great to know that it's happening, and
Yeah.
just because it would be really great to have it, and hopefully like raise up the other
Hmm.
provinces as well. It's great that BC is leading, but wanting to have access for others in Canada
Yeah.
too.
I think also the CPAC, Canadian Partnership Against Cancer, Elimination of Cervical Cancer Action Plan is also a very great information source. And all of the provinces are collaborating and partnering more than ever to um, make that goal towards elimination happen. And that the task force guidelines might be part of that.
That's awesome. And is there time for me to have one more?
Go ahead.
Okay, thanks. I was just thinking about, I have quite a few connections to the transgender and gender nonconforming community, and I think it's one of the reasons I'm so excited about the at home HPV like self collection is that I think it really lowers barriers.
Hmm.
To a lot of the group of people who have cervixes but don't identify as women, and perhaps feel particularly uncomfortable about a speculum exam like at a doctor's office, or just generally
Hmm.
and so I'm just curious if you've done any presentations or outreach particularly to try to get that message to that community.
Yeah, excellent question, Katrina. And the screening program, when that pilot was being conducted, worked very closely with TransCare BC on developing materials and communication materials with that community in mind and receiving their feedback on everything that was being developed. And surveys were also administered to participants in that community as well. So we hope that we have landed on materials that are maybe received by everyone, but that is definitely a community of interest that was taken very much into consideration.